All right, let's get started. We'll turn to page 114. Page 114. Page 114. Seems like it's been a while. Huh?
It's been a while, yeah.
You miss me?
Yeah.
I don't believe it. The last time we met, we were in the middle of talking about gas anesthetics, and page 114, I'm going to backtrack just a little bit before we start again for today. We mentioned the renal effects, and they were pretty simple. The anesthetics do slow down renal function, but not significantly. They depress it like they depress everything. But basically the formula for the ABC of it all is if you have a lower blood pressure, you'll have less renal blood flow, you'll have a lower GFR therefore, and therefore you'll make less urine output. But it's a small amount. We still have a tremendous urine output during the case. We give blood and fluids, we put Foley's in, and we do all that stuff you're used to doing, and everything works out fine. There are no renal toxic anesthetics anymore. I talked about the next little bullet here on 114 was the free fluoride ion issue with sevoflurane, and it doesn't seem to be an issue in that after now well over a decade and over 100 million uses of Sevo throughout the world, there's been no incidence of any renal toxicity. So that was that. The next page under GI, same thing, there's a dose-dependent decrease in GI function. And also I talked a little bit about halothane hepatitis, or really the term I should use is halothane hepatotoxicity, or drug-induced toxicity. And we went through the various things that seem to be associated with it. I won't do it again because it's historical now anyways, since we don't use halothane. But I think that's kind of where we left off last time according to my notes. So let's go to F on page 115, talk about any endocrine, biochemical, or genetic effects. And number one, and very importantly, this is basic dogma of anesthesia, and you'll know this forever. All the inhalation anesthetics are triggers for MH, and therefore absolutely contraindicated in anybody who's MH or MH susceptible or MH suspected or whatever, and except for nitrous oxide. Nitrous oxide is safe. So all the volatile anesthetics, Sevo, DES, and isoflurane are very profound triggers for producing MH. And I did mention a couple times, I think, that there's a whole protocol for doing MH patients. Somebody's going to teach you to, I'm not. But we go through a whole checklist of things, one of them being preparing the machine to make sure there's no volatile anesthetic vaporizers anywhere near that can leak and expose the patient to any sort of molecules of anesthetic gases at all, because that could trigger. And we have to flush the machine with oxygen for half an hour. Some people recommend just taking the vaporizers off the machine altogether and having a special machine ready all the time. It's kind of expensive, but depending on the size of the hospital, you might do that. So anyways, this is a whole malignant hypothermia protocol we all follow. There's a Malignant Hypothermia Society in the United States, and we all follow their recommendations. There's a hotline, so if you ever have what you suspect is a beginning case of MH under anesthesia, you call this 1-800 number, and they have experts immediately available 24/7, and they can talk you through the best approach, what's going on. You just live on the phone with them, and everybody does that if they do have a case. So you'll learn all about that. But back to the pharmacology of it all. The anesthetics are potent triggers, probably the most potent trigger, along with succinylcholine, of an MH attack, except for nitrous oxide. Now the next bullet is nitrous and immune suppression. So I'm going to talk about this for a while. Let's talk about nitrous oxide again. And to do that, let's go to page 140. Page 140. Now let me give you some background. Don't write. Actually, it's because, oddly enough, it's because of some folks abusing nitrous oxide. There was a dentist that was breathing nitrous oxide 10 to 12 hours a day in his office, sitting there with, trying to get high. And he ended up demyelinating himself, where he got to the point where he couldn't walk and all that stuff. It was pretty brutal. But we learned stuff. And bad way to learn, but what are you going to do? And under extreme exposure, that nitrous does have some neurological issues, and spent many years in the laboratory studying this and so on. And what everybody is kind of, the books tend to call it, is they call nitrous oxide and immune suppression. I don't know if that's a good term, but that's the one most people use. And what it involves is this. If you go to page 140, and I'll go in the camera and point. There's a normal biological pathway for producing DNA and RNA and other immune chemicals in the body. This is normal physiology, and that is you take homocysteine and you convert it to methionine and then to DNA and RNA products and so on and so forth. And one of the cofactors required to produce this is vitamin B12. And nitrous oxide seems to, with prolonged use, inhibit vitamin B12. It does it non-competitively. In other words, it does it permanently. Unless you get new vitamin B12, the stuff that's there is rendered not useful. And also it inhibits the enzyme methionine synthetase. I'm pointing to it here on the page. And this enzyme, methionine synthetase, converts homocysteine to methionine. And then you release, eventually release DNA and RNA and so on. So it takes this enzyme, methionine synthetase, and a cofactor, vitamin B12, in order to make DNA and RNA in the body. And with prolonged exposure, nitrous oxide can inhibit this. So, well, let's look what it says under this figure 31.1 on page 140. Nitrous oxidizes the cobalt atom of vitamin B12, inhibiting methionine synthetase and causing the accumulation of homocysteine and disruption of the deoxythymidine synthesis, etc. So therefore it would interrupt the production of DNA and RNA and some of the immune products and so on. Most of the books call it loosely immune suppression from nitrous. It really is more specifically blocking DNA and RNA production. And then I put this little thing on the bottom, page 114. I found it in an article. I just took one paragraph out. Interestingly, in the past several years, possibly coincident with the publication suggesting higher incidence of both cardiac and adverse outcomes, nitrous has declined in the use has declined in the United States. 33% of all general anesthetics given in 2009 were given with nitrous. Only 21% of those in 2011. So you see nitrous is slowly going to the scrap heap. But we still, about 20% of the cases still use nitrous. And I think it's a safe drug, and it does have benefits. But nonetheless, you're going to work with a lot of people that just don't even bother anymore. And this is one of the reasons. because nitrous producing immune suppression. Now, you have to give it for, most people say, at least 6 hours to see this as an issue, and it's usually in debilitated type patients. And I'll show you if you go on the next page. Page 141 is a table on the top, and I've got this all there written for you. These are patients that would be at risk for cobalamin deficiency, in other words, vitamin deficiency. So they would be at risk for vitamin B12 deficiency, and on top of that, if you give nitrous oxide and block vitamin B12, let's see, then you got a double whammo. That's not a good thing. So who do they mean? Well, obviously then, it's going to be somebody with nutritional disorders. They have low vitamin because they had bad nutrition. That includes elderly who may be not eating right, or vegans who don't eat right because they're vegan, and alcoholics because they are vitamin suppressed. Somebody with malabsorption disorders, they can't, GI disorders where they don't absorb proteins and vitamins properly. People with prolonged use of PPIs, proton pump inhibitors, very a popular class of drugs to administer in the United States, or H2 blockers, Zantac and Prilosec and all the rest of those. Somebody with pernicious anemia, atrophic gastritis, somebody who's had a gastrectomy or Whipple procedure, some sort of bowel resection, someone with Crohn's disease, or a tapeworm. I'm not sure how many people you put to sleep with a tapeworm, or some kind of a bacterial or fungal infection and so on. So that's kind of stretching the list, but nonetheless, these are the people you would suspect might be vitamin deficient in the first place, so you don't want to be giving them nitrous oxide and making their problem worse. So the author then comes to these conclusions: recommended indications and contraindications for the use of nitrous oxide in anesthesia practice. So absolute contraindications. These are the people you can't give nitrous oxide to. If they have a known deficiency of enzyme or substrate in the methionine synthetase pathway. In other words, if they're vitamin deficient. Those people on the table above, right? People where there's a potential toxicity from expansion of nitrous into gas-filled spaces. We talked about that already. He mentions people with emphysema, pneumothorax, middle ear surgery, pneumoencephalus, air embolus, or some types of raised intracranial pressure. Some relative contraindications: for prolonged anesthesia greater than 6 hours, people with pulmonary hypertension, because nitrous can cause some vasoconstriction in the chest. Pregnancy, we do not give nitrous to pregnant women. It's the only suspected teratogenic anesthetic, and I'm going to talk extensively about that in just a couple of minutes. And people who have a high risk of nausea and vomiting, because nitrous, although it's not universally believed, but it's certainly to some extent believed that nitrous does increase the incidence of PONV. So if somebody's especially prone to getting nauseated and vomiting, and we do certainly have a lot of those patients, then you don't want to give them nitrous. Then he's saying putative, or maybe it's a relative contraindication, somebody with myocardial ischemia. And of course, if you're giving nitrous 50, 60, 70%, you're not giving as much oxygen, and maybe that's can be somebody with myocardial ischemia. You want to bump the oxygen up a little bit. So that's recommended indications and contraindications for nitrous oxide. Now, on the next page, the last page, 142, I put a couple of little blurbs in here. And so I'm not going to go through this whole thing. You can look at it nonetheless. Just on the top, under nitrous oxide, page 142, Does administration of nitrous make a difference in patient outcomes? On the basis of evidence, I believe that it does. Now, this is this person writing. Nitrous should be avoided in patients at high risk of PONV, especially when propofol-based maintenance anesthesia will not be used. Propofol is antiemetic, so he's saying if you don't use propofol and you're not giving an antiemetic, then it's even worse if you use a nitrous because it's emetic. Current evidence is insufficient to support the maintenance recommendation to avoid nitrous in patients at a risk of major cardiac events, pulmonary atelectasis, infectious complications, and neurodeficits. The omission of nitrous is not a risk factor for awareness. If you're going to get a case of awareness under anesthesia, it isn't because you didn't give nitrous, it's because you didn't give enough of the other drug you're supposed to be giving. Right? So you just paralyzed them and didn't give them any drugs. Then jumping down to the end, I just thought it was a cute statement. He says, "Isn't it quite remarkable how little definitive evidence we have regarding nitrous, the oldest anesthetic drug there is? It was discovered in 1840. Many questions are still unanswered. Is the use of nitrous safe in vulnerable populations? Could nitrous have any benefits, as recent studies suggest? Is there a low risk of chronic pain after surgery? Is the acute increase in plasma homocysteine of any relevance, etc., etc.? We don't know. So it's funny that a drug's been on the market for 200 years, has this many questions, been given literally hundreds of millions of times, still has questions raised about it. Okay. So back to page 115 then. That's nitrous and immune suppression. This is what I'm going to ask you on the next test. What is the enzyme that's inhibited by nitrous oxide that blocks the synthesis of DNA and RNA? And what's the answer you're going to give me? Methionine synthetase. What's the cofactor that's inhibited by nitrous oxide for methionine synthetase? And your answer is going to be vitamin B12, right? This is basic anesthesia 101. You need to know it. Put a little note next to it. There you go. All right, the third bullet on page 115 under F, free fluoride ion and sevoflurane. I think I beat that one to death, so we'll move on. And the fourth one, there is no fourth one, but I want to put a fourth one in there. I'm on page 115 under F. There's 3 bullets. We did nitrous and immune suppression. Free fluoride ion and SIVO I talked about last class. The fact that SIVO does produce free fluoride ion, but does not produce renal toxicity. Now, the fourth bullet, there isn't one, but I'm adding one right now, because why not, is cancer. Let's talk about cancer in the anesthetics. This is an area of tremendous research nowadays, and I have a little blurb on that on page 138. So go to page 138. Here's the question. We do a lot of cancer surgery. That's one of the main reasons people come to surgery, is because they have cancer and they're getting some kind of cancer removed. Does the anesthetic play any role in either inhibiting the cancer from further spreading and or causing the cancer to further spread? Is there anesthetic differences in the type of anesthesia we can give for oncology surgery? So this is a table out of my chapter in the book, and the effective anesthetic technique on cancer recurrence and metastasis. There's several large-scale studies going on right now, especially in Canada and in Europe, regarding the incidence of cancer metastasis or the spread of cancer. What we've known for many decades is when you operate on a cancer, you spread it. Or you take it out, you get rid of the tumor, but by handling it and moving, and cutting it open and manipulating, you also spread the cells. And that can promote metastasis. So that's kind of a double-edged sword. Yeah, you got to operate and try to help the person, but at the same time, you may, in fact, spreading it to some extent by doing surgery. Now we're looking at the anesthetics. Is there a better technique to use for cancer surgery over another? So this is out of a Canadian journal. I wrote this table out. 2016, there's a reference down there. And there's the volatile anesthetic, so let's look at that. And the effect on cancer recurrence and or metastasis is conflicting evidence. Some in vitro studies suggest there's an enhanced expression of tumorigenic markers, migration of cancer cells, angiogenesis. Angiogenesis is the process where you grow more blood vessels to supply the tumor. Cancer tumors generally get their own blood supply. They grow blood vessels to help feed blood into them so they can grow faster. So angiogenesis is the process, and there's a lot of anti-cancer drugs that work by blocking angiogenesis. They block the blood supply to the cancer and hopefully then kill it. So migration of cancer cells, angiogenesis, and metastasis in tumors. There's insufficient evidence exists to avoid in cancer surgery. So far, the data doesn't show anything definitive, so we still use gas in cancer surgery. As far as nitrous oxide goes, it has no impact on cancer recurrence. Of the local anesthetics, if you want to do local for a particular case, there's a reduced cancer recurrence and metastasis secondary to the anti-inflammatory actions of the local anesthetic. So local anesthesia is good. Neuraxial anesthesia, in other words, spinal and epidural, there's conflicting results, but generally it's thought that they're beneficial. They reduce cancer recurrence and metastasis by attenuating the immunosuppressive consequences of the stress response and possibly an opiate-sparing effect. The NSAIDs, they are beneficial. They help inhibit cancer growth, metastasis, and so on. But by blocking cyclooxygenase, we'll talk about that at the end of the semester. Their beneficial choice is analgesic in cancer patients, so they're actually preferred as an analgesic drug in people with cancer. Aspirin, same thing. Opiates are the bad ones. They seem to promote cancer recurrence, metastasis, etc. And they promote cancer progression and reduce long-term survival. They promote cancer cell growth, inhibit cellular immunity, enhance angiogenesis and tumor cell signaling pathways. They inhibit natural killer cells. Giving oxygen, supplemental oxygen. Post-op can have a shorter cancer-free intervals period because it has an angiogenic effect on the micrometastasis. And steroids, dexamethasone, no effect. So that's kind of the current wisdom as to what's what. Since we're talking about the gas anesthetics, then it seems that there's not enough evidence yet to avoid them. There's some evidence they're not good, there's some evidence they're good. So right at now, it's still up in the air. Nitrous is fine, the other ones are fine, still okay. On the next page, 139, this was a little drawing. I kind of liked it. I stole this out of the reference on the bottom. Anesthesia and Analgesia, one of our main journals. And this artist kind of drew a picture to show what we've been talking about. So again, this is page 139. And he's going across the thing, a little scale. Potentially improved outcomes in cancer, potentially worse outcomes in cancer. Here's the scale. And he said the NSAIDs, propofol, and local anesthetics possibly improve. The opiates and volatile anesthetics potentially worsen. So it's a little bit, he's on the worsen scale. Most everyone else is in the we don't know yet scale. So despite the trends illustrated above, To date, neither the choice between regional or general or a single drug class has proven consistently beneficial or harmful in terms of tumor recurrence in patients undergoing cancer surgery. So that's that. Good. Okay, back to page 115. And for OB and Peds, so this we're going to talk about for quite a while. OBs and Peds. My first bullet on page 115 is nitrous oxide is contraindicated in pregnancy. It's teratogenic in animals. All right, so teratogenic means it causes birth defects. The only one that does, of all the anesthetic drugs we use, is nitrous oxide. And there's even some question whether nitrous in normal use does it, or you have to really use, like that dentist doing it 12 hours a day or something. So, but because it theoretically, or at least in mice, rats, and some lower species animals, it does cause some birth defects, then why take a chance? You don't need nitrous anyway, so forget about it. So we don't use nitrous in pregnant women. Now, I want to stop and put your pen down and let me talk for a minute. You got to remember, first of all, for us, when we talk about not giving a drug to a pregnant woman or giving a drug to a pregnant woman or whatever, you can see, for example, if a woman comes for surgery and she's 5 months pregnant, I don't know, just make it up, I'm not going to want to give nitrous oxide because it's known to be contraindicated. However, if a woman comes to surgery for a C-section and the baby's going to be delivered, I can turn on all the nitrous oxide I want. Why? Because the baby's coming out in 3 minutes and it's not going to get a birth defects in the next 3 minutes, right? So we always separate in our minds when you read about drugs going to pregnant women. It's different for delivery, is what I'm trying to say. You don't worry about a birth defect during delivery. So we can do a different technique for that. Now in general, I'm just talking in general. When you talk about giving drugs to pregnant women, first of all, if a woman needs surgery and it's elective, you don't do it. We don't ever do surgery during pregnancy for elective procedures, ever. So that's rule number one. That's easy. Why would you? Secondly, if you're going to be exposed to a drug that's going to cause harm to the baby sometime during pregnancy, this common wisdom is it's going to happen in the first trimester. Because the first trimester is when most of our organogenesis is occurring. The organs are being developed, the neural tube is being developed, so most of the time it's just general, classroom wisdom that in pharmacology, that if you're going to mess around, if you're going to give a drug to a pregnant woman and cause harm to the fetus, it's likely to happen, more likely to happen, during the first trimester. Now, there's a lot of exceptions to that, as you'll see when we talk about more specifics. But that's the general thinking. Okay? By the third trimester, the baby's pretty formed, and you're not really worried about birth defects as much as you may be worried about causing premature labor or causing a miscarriage or that kind of thing. So it's not a matter of harming the baby, it's a matter of harming the progression of the pregnancy. And that's where things come in. So let's take a look at the bottom of page 115. I got some right things in here. So all anesthetics except nitrous are used during pregnancy. Now you notice my second bullet. All inhalation gases relax the uterus. So you don't want to relax the uterus in a pregnant woman because you're going to mess with uterine tone and maybe produce spontaneous labor if the mom's 4 months pregnant and you're messing around with the uterus with a drug. Then next thing you know, she goes into labor after surgery. The most common time for that to happen is usually 1 to 7 days post-op. The mom will have a miscarriage or some sort of an issue, and it's never really clear, even up to this day, whether it's the anesthetic drugs, whether it's the surgery that she had to undergo because she had to undergo it, whether it's some disease process, an infection. Let's say you had an appendectomy and you got an infection in your appendix. Is that what's going to cause the problem? Or is it a combination of all? The surgery, the stress, the anesthesia? Is it just add everything up and that's what causes the mother to have harm? And it's not really clear. Why? Well, you can't do studies in pregnant women. You're not going to get mom to agree, well, let me give you this drug and see how it hurts your baby. And it's stupid, right? And it's unethical, and you'd be put in jail, rightfully so. That's what they call Frankenstein. So you're not going to have studies. So everything's going to be anecdotal. Or, you find stuff out from just generally things that have gone on over the years. The biggest issue in pregnant women, also, and let me finish my little warm-up by saying this, there's less of an issue of being exposed to a drug once for a couple of hours than there is to be on a drug chronically. For example, the example they always use in drug pharmacology books is, let's say you're a woman who wants to get pregnant and you have a seizure disorder, a serious one. You're on anti-seizure drugs, epilepsy drugs. And several of them are known to cause harm to the baby. So you have to work very closely with your OB and genetic counseling, and there's a whole process that will go on for the 9 months of the pregnancy. Because you have to take that drug every day, you're going to have a seizure, and that's not going to be good for the baby either. So it's there's trade-offs on both sides. When we're there, we may give mama a spinal for an hour and a half case. Is that as likely to cause an issue? No. Can it cause an issue? Yes. But it's not as likely than as somebody who's pounding a drug down every day, all day, for 9 straight months. You see what I'm trying to say? So there's a risk issue with taking care of pregnant women. As I've mentioned several times, we do the majority of OB anesthesia in the United States, we being CRNAs. So we do a lot of pregnant women, and we have to deal with these issues on a daily basis. So let's take a look at the bottom of page 115 and start to go into this a little bit. All anesthetics except nitrous are used during pregnancy, but you don't want to relapse the uterus. Here's what happens. There's studies showing, I'm not going to show you this, but if a woman has uterine surgery, let's say she has fibroids or something wrong with uterus, needs surgery, and I use a gas anesthesia technique versus a spinal. It's very well documented, and it's been done for decades, that the woman getting the gas anesthetic technique is going to have 3-4 times as much bleeding as the woman who has the spinal, because the uterus gets relaxed. And I feel inadequate as a man standing in front of largely a group of women explaining that the uterus has to contract for you not to bleed. So uterine cramps, I don't need to explain to you, are one of the ways, the primary ways that the uterus gains hemostasis. And so when you relax the uterus with a drug and cause uterine relaxation, then the uterus is going to bleed more if you're operating on it, because one of the ways it doesn't bleed is to contract, and you're blocking that. So there's no doubt about it. We all know. If you're going to do, now again, if you're having a hysterectomy, you're taking the uterus out altogether, it doesn't matter. But if you're doing some intrauterine surgery or something where the uterus is going to stay in post-op, then there's going to be more bleeding if you use an anesthetic gas because you're relaxing the uterus. Now, it's going to reverse itself when you wake mom up or the woman up. This doesn't even have to be pregnant. This is regular surgery, uterine surgery. But nonetheless, you have to be careful. And so we tend to not give high concentrations. Look at my thing. Look at the bullet under number 8 on page 115. All inhalation gases, except nitrous, of course, relax the uterus. Low concentrations are used in C-sections. So if mom's going to have a general anesthesia for a section because of fetal distress or mother's distress, You gotta go in, crash with propofol, intubate, and you're gonna turn on a low concentration of gas. Most people stay 1 Mac or less. Because then the uterus doesn't relax too much. The OB can get in there and get the baby out. And then as soon as the baby's out, you gotta get the uterus to constrict, right? To stop bleeding. So we give Pitocin and we pump it in, IV, drip, and so on immediately after the baby's delivered. And Pitocin will still work if the anesthetics are around. But we purposely try not to. We give some, but we don't give a lot. Just so we give a lot of uterine relaxation. All right, does that make sense? All right, let's take a look. Bottom of page 115. I've already said this about 5 times. I keep forgetting. I remember stuff. All anesthetics except nitrous are used during pregnancy. The anesthetics depress and thus relax the uterus. Administration of anesthesia during pregnancy is associated with an increased risk of post-op miscarriage. However, no single agent has been implicated. The same risk has been linked to other techniques. So even a spinal or local, they still have an increased risk of miscarriage. So maybe it's not the anesthetic, it's actually the surgery or the whole process of everything, isn't it? Low concentrations have minimal effects and are used with IV supplements to produce anesthesia in pregnant patients undergoing non-obstetrical procedures. Uterine relaxation may also increase blood loss during intrauterine procedures, and nitrous is again contraindicated for all pregnant women. You can turn it on during delivery, but you would never turn it on during pregnancy. Right. So, let's move to page 123. Page 123. Now, again, let me tell you a story. Many years, when I was first training, in the first 20 years I was in anesthesia, we didn't have scavenging systems on the machine, and you saw in that little ether movie, the guy actually stuck the jar in his nose and went, trying to make sure it's ether or something. I don't know. So we were exposed to quite a bit of anesthetic gases. And there was some epidemiological studies. One of them was a very large study done in Michigan. It was a questionnaire study, and they did among female CRNAs, actually they did males too, an anesthesiologist, and they compared them against a control group of pediatricians, female and male pediatricians. And they found that we, not me personally, but we, the female members of our society, were having an increased number of miscarriages, birth defects. Male CRNAs seem to have a higher incidence of female children for some reason. And so there were some concerns. And, it's a survey that you pick paper and pencil, so it's not a well-controlled, scientific, double-blind, study. But nonetheless, we don't like bad stuff to happen to us, especially. So there was concern. Now, jumping up to 2017, we know this. Now that we get very little exposure to the anesthetics, if you practice properly and you're going to learn from the clinician, people who teach you how to make sure you don't expose yourself to a lot of gas, and the people in the room that are working with you, it's nice to them too, surgeon, the OR nurses, and so on. If you don't leave a mask sitting on the, while you go to intubate, turn the gas off while the mask is sitting there so you're not flowing gas into the room, and use your scavenging system. And there's a whole bunch of little techniques that are very easy to just incorporate in your everyday without even thinking about it in practice, to keep the amount of anesthetic we breathe to a minimum, and there's not really much of a problem anymore. Women who get pregnant nowadays, anesthesiologists and CRNAs, do two things. They don't expose themselves to nitrous oxide, So they'll only go in rooms where nitrous is not being used, or they'll turn it off when they go in there. If they're going in to give a coffee break or whatever. And number two, you stay away from x-rays, and that's kind of common sense, right? So you do a lot of x-rays in surgery, so you don't want to be in a room. You're not going to do orthopedics cases for the day, because all they do is x-ray every 3 minutes. So you're going to stay out of ortho rooms, you're going to not expose yourself to nitrous, and you'll be fine. Currently, the big problem with exposure of working personnel to anesthetics is in dental workers, especially dental hygienists, because the patient's got a little nose mask of nitrous on, their mouth's wide open, they're breathing into the face of the dentist and the dental hygienist, and they don't have any scavenging because it's just blowing out in the air. And so they actually get exposed to very high levels of anesthetic gases. And we're very, very minimal levels. So it's not really an issue for us. It's more of an issue for dental workers and for PACU nurses, because in the PACU, you get all these people waking up, blowing off this gas, and the PACU nurses are being exposed. Although they're heavier than air, they tend to concentrate to the bottom. They're exposed more than we are. So, that having been said, there's been an awful lot of work. You'll learn all about it. The government makes you design the room so the air in the room turns over 14 times every hour. It's all fresh gas. There has to be special ventilation systems, and you have to machines checked and measured, all the connections. You got to keep a log, all the wall connections. I mean, there's a whole big process. You have to be certified. You have to report to the government. So there's a whole big to-do now, which you'll learn about from somebody, in order to keep us from being exposed. And I'm all for it, believe me, to a lot of gas. So let's take a look at page 123 at the top. Inhaled anesthetics present the potential for adverse reproductive or developmental effects for patients and healthcare personnel that are exposed to waste gases, patients blowing out. Exposure to waste gases occurs because of leaks into the system, because of mask, high pressure fittings, and the exhalation valves. Good practice in tracheal intubation results in low exposure. Recognition of post-op exposure in the PACU and ICUs represents another challenge. To control occupational exposure is not sufficient to adopt scavenging systems in the operating room. That protects us, but what about the PACU nurses and all the rest of it? Working environmental controls and occupational management are required throughout the peri-op process. So the standard levels, accepted government levels for nitrous are 25 parts per million, and for any halogenated gas, it's 2 parts per million. And when the Joint Commission comes in, they can measure if there's more than 2 parts per million in the air in the operating room, and they're going to cite you for violating the levels themselves. Healthcare personnel can be exposed to waste gases both in and out of the operating room. Lab studies suggest reproductive abnormalities in animals exposed to high concentrations of nitrous. However, no human studies have ever been done for obvious reasons. Teratogenicity, which has been demonstrated in animals chronically exposed to nitrous, is a specific concern in pregnant CRNAs or surgeons, anybody in the operating room that's pregnant. Potential post-op exposure to healthcare workers to exhaled gases in PACUs, ICUs, and other patient care areas should be recognized and should have good practices to try to keep it to a minimum. So that's kind of the story with that. Seems to be okay. There doesn't seem to be any big issues for us, the workers, other than, like I said, for women when they do get pregnant, minimize your exposure to nitrous oxide and to x-rays. Now, what about pregnant women that are patients? In other words, not just us workers. What about the patients? So turn to page 124. Page 124. In the past decade, elegant work from animal studies has conclusively shown anesthetic agents can cause neurodegeneration. More than 80,000 patients undergo non-obstetric surgery in the United States every year. So 80,000 pregnant women need surgery every year. Right? You only do it if it's an emergency. As they say, despite the popularity of spinal techniques and so on, many pregnant women continue to require general anesthesia for pregnancy-related problems, including cesarean delivery, trauma surgery, surgery for acute surgical conditions such as appendicitis, cholecystitis, or for various fetal interventions. Another very common pregnant woman required surgery is a ruptured cyst, ovary, or a cyst in the reproductive system. That's an emergency. You have to save the mother, so they would require surgery. Although the use of general anesthesia during third trimester has not been determined precisely, the incidence can be as high as 5%. So, now let's take a break off. Codex. Okay, let's get started again. Okay, back to page 125. 125. All right, so go to the top under summary. Third trimester fetal brain seems vulnerable to both inhalation and IV anesthetics. I'm going to talk about that more in a minute. Most IV anesthetics have been investigated except for dexmedetomidine, can produce adverse neurodevelopmental consequences. Human studies are unequivocal. General anesthesia during C-section is not associated with learning disabilities. There's a possible association with an increased risk of autism. The presence of numerous confounding factors make any kind of determinations at this point speculative. So the risk of commonly prescribed drugs in the peri-op period during pregnancy. Let's look at the inhalation anesthetics. Exposure to nitrous when scavenging systems are not in place has been associated with an increased risk of miscarriage, spontaneous abortion, in dental workers. There's also emerging evidence that inhaled anesthetics may have neurodevelopmental effects in children. We'll talk about that in a minute. Muscle relaxants do not cross the placenta. Opiates, of course, we have a lot of information on opiates in pregnancy because there's been half a century of pregnant women who are drug addicts. So we have had a lot of study of the administration of narcotics to women who are pregnant all the way through pregnancy and so on. And it doesn't appear to cause any issues. The baby can come out addicted, but as far as our use, just in pregnant women, it's safe, and that's preferable actually than giving a lot of gas. The NSAIDs should be avoided because they can cause your constriction of the ductus arteriosus. Local anesthetics are safe except for cocaine. And there's X-rays, and of course they're contraindicated. And then I'm on page 126. Non-obstetric surgeries or procedures requiring anesthesia during pregnancy. So let's sum this up. Published reviews have shown that most non-obstetric surgeries performed on pregnant women were either appendectomies or cholecystectomies, but also can have surgery for cancer, neurocardiac, and trauma surgery. Non-surgical procedures can include endoscopies or ACT. Before any procedure is performed, adequate counseling should occur and the patient should be aware of the risks. ACOG, which is the Obstetrician Society, in its 2011 committee, advises there's little data to make specific recommendations. They do have generalizations they can make, include that a pregnant woman should not be denied indicated surgery. Elective surgery should be delayed until after delivery. Non-urgent surgery should be performed if you have to perform in the second trimester if possible. If you're going to do surgery on a pregnant woman, of course, there's going to be a team of people in the hospital. Obstetrics, obstetric nurses, the surgeon, the anesthesia. I mean, you're all going to get together. You're going to sign consent. They're going to have lawyers. They're going to sign consents up now till doomsday. So it's a big process. But generally, you can get it safe, and usually it doesn't cause any harm. As I said, there is an increased incidence of miscarriage post-op. But other than that, and I don't mean to minimize it, but all I'm saying is if a mom has an emergency appendectomy, and generally it'll go okay as long as you have the right people in the room, have an obstetrician present, they can monitor the baby, maybe an OB nurse, and so on and so forth. And that's it. Pre-op recommendations from ACOG, coordinate care, and as I said, they get a whole team of people involved, which of course we naturally will. The gestational age of the fetus should determine or help guide management. In general, 24 weeks or greater is considered viable. So if the mom does go into labor, you can deliver the baby, etc. And so you're going to get the OB people in there to take care of that stuff. On the next page, 127, intra-op recommendations. Immediately before the procedure, the fetal heart rate should be documented. If the fetus is viable, they recommend fetal heart rate monitoring during the case. So you want to get an OB nurse in there to help with that. Healthcare provider with OB surgery privileges, another an obstetrician, and so on and so forth. As far as pre-op pregnancy testing, this is another kind of a side issue that happens every day in surgery, because we have every day women come to surgery during childbearing ages, and you put them have them do a pregnancy test to see if there's a possibility they're pregnant before you put them to sleep. And every department in America has a guideline and protocol that they follow. Some departments mandate that all women in childbearing age who are sexually active will have a pregnancy test preoperatively. Others interview the woman, and if she's not sexually active or has recently had a menstrual period, they may not do a test. It varies from department to department. So whatever the department you happen to be working in that day, I guarantee you, will have a very hard and fast protocol for how you handle young women of childbearing age who could possibly be pregnant, and so you want to know that before you take them to surgery. So let's take a look at this. On page 127, pre-op pregnancy testing. There are many changes that occur during pregnancy and changes in clinical care when a patient is known to be pregnant. In the most recent update, the ASA task force state there's insufficient data to adequately inform patients of the risk of anesthesia or surgery in early pregnancy. Pregnancy testing may be offered if the result will change management. Review of the literature found that a positive urine test in pre-op was reported in 0.3 to 1.3% of the patients. So it's not a lot of people coming to surgery that will be pregnant and not know it, but there is, 1%. Many institutions have developed their own policy, making testing mandatory for any woman of childbearing age. Others make it required if the date of the last menstrual period is greater than 1 month but less than 1 year. So you have to go by whatever the policy of your department happens to be. So summary. Pregnant patients need special consideration when undergoing any surgery or any procedure. An understanding of the normal physiological changes, etc., will help you provide the best care possible. Yes.
I heard that pregnant CRNAs giving pediatric anesthesia because they do a lot of inhaled inductions. That could be a little bit iffy. Is that
Yeah, that is. Female CRNAs or anesthesiologists who are pregnant and do peds because you're always breathing the gas. They tend not to want to do that, or they'll only do older. If you work in a pediatric hospital, they'll only do older kids who are being intubated, and they won't do the mask inductions. Yes, that's you want to minimize your exposure. So yeah, that's exactly right. So not only nitrous, but if you're doing adults, you don't have to be exposed at all. But if you're doing kids, you do. So you want to minimize. Okay, let's wrap this up by saying this. On page 129, and this is non-anesthesia drugs, but just drugs in general. Page 129. This is for the references on the top of the page. And I just like the way that they did these little key points, so I stuck it in here. Physiologic non-anesthetic drugs during pregnancy. Physiologic changes of pregnancy alter drug disposition and drug effects. Maternal drug therapy is relatively easy to manage by changing the dose or switching the drugs or whatever. So that's the obstetrician's issue. General and local requirements are reduced during pregnancy. Appropriate maternal treatment is essential to maintain fetal health. Mothers are concerned about many adverse fetal outcomes, including teratogenic effects, fetal loss, growth restriction, preterm labor, and other complications. The basis of safety for many drugs during pregnancy is a long history of uneventful use. So the way you know the drug's safe is if you've been using it for many, many decades, there's never been a problem, then it's safe. FDA has pregnancy categories for every drug. They're always listed in the package insert. Almost all the drugs, I'm going to say 90% of the drugs are, in the old category, is category C, meaning we just don't know. We have no testing, we have no way to do studies, because the women are pregnant, you don't want to do studies. But as far as we know, so far nobody's reported any issues. If it's a known teratogen, or it does cause problem, then it's classified as such, and it would not be given. Critical period for organ development extends from approximately day 31 to 71 after the first day of the last menstrual period. Administration of anticonvulsants is associated with problems, as I mentioned. Heparin doesn't cross the placenta. Low molecular weight heparin is generally the anticoagulant of choice in pregnant women. Most antibiotics are safe during pregnancy, although tetracyclines should be avoided because they can cause black teeth and inhibit bone growth. Vaccinations recommended in pregnant women if you don't use live vaccines. Flu vaccine is very recommended in women. Most drugs are safe to use during lactation. Typically only 1 to 2% of the maternal dose appears in breast milk. And codeine is rapidly converted to morphine by some mothers, leading to a lot in the breast milk. So don't take codeine if you're breastfeeding. That's some kind of general things. Now on the next page, finally, here's some anesthetic specific issues. We've talked about most of these. A significant number of women undergo anesthesia and surgery during pregnancy for procedures unrelated to delivery for emergencies. Maternal risks are associated with anatomic and physiologic changes. You can have difficult intubation, aspiration, and so on. The diagnosis of abdominal conditions is often delayed during pregnancy because of the size of the abdomen and the fetus in there and so on. Maternal catastrophes involve severe hypoxia, hypotension, acidosis, and those cause the greatest risk to the baby. So something bad happening to mom is the greatest risk to the baby. Other fetal risks associated with surgery include the usual fetal loss, preterm labor, growth restriction, and low birth weight. Clinical studies suggest that anesthesia and surgery during pregnancy do not increase the risk of congenital anomalies. It's unclear whether adverse fetal outcomes result from the anesthetic, the operation, or the underlying maternal disease. No anesthetic agent is a proven teratogen in humans, except nitrous oxide is in animals, so we don't give it. Many anesthetic agents have been used for anesthesia during pregnancy with no problems. Make sure you just avoid hypoxia, hypotension, acidosis, etc. Okay. Enough of that. Now let's go to page 116. That's OB, let's talk peds. This is a current major controversy in anesthesia, so let's talk about it. Page 116. There are current studies being done and been done recently that show that anesthesia is toxic to neurodevelopment in kids. Children under 3 years old exposed to anesthesia, animals under 3 years old, equivalent of 3 years old, exposed to anesthetics show brain issues, degeneration, developmental neurotoxicity. So let's take a look at this. That's on page 116. A great deal of concern has arisen regarding the safety of anesthesia in infants and children. There's a growing body of evidence in animals that anesthetics can be toxic to the developing brain. Proposed mechanisms of neurodegeneration in newborns include activation of intrinsic and extrinsic apoptotic cell death pathways. Apoptosis means cell death. An estimated 6 million children, including 1.5 million infants, undergo surgery and anesthesia in the U.S. alone, so this is a big issue. 3 large-scale studies have just been completed to address this, and it hasn't really addressed this. I mean, I can have you just take a look at it. So on the bottom of page 116, the U.S. FDA has this year issued a warning that repeated or lengthy use of general anesthetic and sedation drugs during surgery or procedures in children under 3 years old or in pregnant women during the 3rd trimester may affect the children's developing brains. This is totally based on animal studies. They note recent human studies suggest a single short exposure to general anesthetic and sedation drugs in infants and toddlers is unlikely to have a negative effect. I'm on page 117 on the top. In the U.S., clinicians can recommend that parents, they've developed, anesthesia societies have all got together and developed a website, and it's called Smart Tots website, and there's the address, and it talks about all the studies and the issues, the ongoing issues, and so on. And they say the FDA recommends you refer moms and dads to this website. I'm not sure it's a good idea. The website contains useful resources and consensus statements created by experts. Until proven otherwise, it can be recommended to keep anesthesia and surgery as short as possible in children under 3 years old. Use short-acting drugs in a combination of general and multimodal pain therapy, including analgesics, local or regional anesthesia. So, there's some of the possible mechanisms for the neurotoxicity. I'm not going to go through them. You can take a look at them yourself. It's all pretty speculative. But I want to go to page 118. This is an editorial that was this last couple months. Was in the New England Journal of Medicine. And anesthesia in developing brains. what are the implications of the FDA coming out and putting a warning on all the anesthetic drugs that they're possibly neurotoxic. For more than 15 years, the potential for lasting neurotoxic effects of general anesthesia and sedation administered to young children, indirectly through pregnant women, or directly to the kid, has been a subject of concern. The topic has been a focus of 3 public hearings by the FDA, and they came out with recommendations. So far, it's only animals, not in children. All the studies show that. I'll jump to the bottom here. On December 14th, 2016, this is December of last year, the FDA issued a drug safety communication warning that general anesthesia and sedation drugs used in children less than 3 years old, pregnant women in the 3rd trimester undergoing anesthesia for more than 3 hours, or repeated use of anesthetics may affect the development of children's brains. This warning was a result of for a labeling change of all our anesthetic drugs had to change their labels to reflect this. And next page, 119. As of the 2014 warning and label changes, several recommendations have been considered. I put this part in bold. This is the physician writing the editorial. He writes, "This warning will raise concerns and questions among practitioners, pregnant women, and parents of young children. Questions for which there's no clear answers. It could change medical practice for many of the estimated 1.5 to 2 million children undergoing under 3 years age undergoing surgery." And they go on to talk about it further. So I don't have an answer to this. This is an ongoing, as you can see, these are current, couple months ago editorials, etc. There's major studies you can bet going on. There are. We're all participating in them, CRNAs, anesthesiologists, etc., and all of our respective professional associations, along with the FDA and CDC, are participating in these studies to try to see. It would be very important to know whether administering anesthesia to a 1-year-old, for example, will cause some behavioral developmental issues later in life. Again, there's only animal data and nothing in children so far. The only recommendations that have come out is try not to do surgery if you don't have to. If you have to, keep it short if you can. And that's not much of a recommendation. We knew that already. So anyway, there you go. Okay, now the next thing I want to do, on the bottom of page 119, you see the words postoperative cognitive dysfunction. See that? I was supposed to put it on the top of the next page, but it didn't. So that's really the heading for the next page. But I messed up. Now, post-op cognitive dysfunction, I'm not going to mention it, but you see I only put a few sentences in there. But this has to do with the elderly, and there is some data that elderly people, if they have surgery, can have some cognitive dysfunction post-op. That's been known for decades. Certainly, in open heart surgery, it's a well-known problem, is that patients can wake up confused and stay confused for many weeks post-operatively. The same can happen for just routine surgery, general anesthesia in elderly patients. And somebody who talks to you about geriatric anesthesia will probably mention it, but I'll just kind of put a little blurb in there just to say it. Post-op, I'm on top of page 120. Post-op cognitive dysfunction, the POCD, that's generally meant to mean elderly patients. As a result of surgery and anesthesia concern in the elderly, a recent study of 8,000 twins, how did you recruit that? Find 8,000 twins. One having surgery, the other one not. A negligible but statistically significant decrease in sensitive composite cognitive scores was present in the twins with at least one major surgery. no difference in intra-pair analysis. So, the elderly can wake up confused and stay confused for several days post-op, whether that has to do with surgery again, or stress, or the drugs, us. It's not real clear at this point. But I just wanted, because if you see the term POCD, it's referring to confusion in elderly patients post-operatively. I'm differentiating away from the neurodevelopment effects in kids that we're studying as we speak. Okay, now finally, well, not finally, but on page 120, we're going to talk about, I want to talk about emergence phenomenon in children. Okay, this one's pretty simple. It's been around forever. We know about it. And what can happen is kids can wake up kind of crazy, basically. I just put it in street language. Young children, especially, and even teenagers, when they wake up from anesthesia, can be very combative, confused. This happens in the PACU. All right, then they wake up and they go home and they're fine. So this isn't a long-term cognitive issue. It isn't a neurodevelopmental issue. This is an issue during emergence. And any of you have had a chance to practice PACU nursing can attest to this, that there are certain patients, young patients, that seem to wake up kind of crazy, confused, combative, rolling around the stretcher. You have to watch out they don't bang their arms and legs and whatever. We call it emergence delirium, ED. There's another ED they're always advertising on TV about. That's an old guy's. This is ED in kids. Emergence delirium, here I'm on page 120, occurs after the use of SIVO and DES in preschool-age children in the post-anesthesia care unit. It seems to be most always associated with SIVO. A little bit of DES, but we don't use DES that much in kids. And so a lot of people thought, well, maybe they're just waking up too fast. Maybe they're waking up so fast that they're getting the sensation back, and the lights and the noise, and it's making them confused. And they've done all kinds of studies, and it doesn't seem to matter. They just do it. I'm not sure why. Symptoms usually last approximately 15 minutes, resolve spontaneously once the child eliminates more of the anesthetic. So once they emerge through stage 2, they're not in this excitement stage anymore, then they calm down and they seem to be okay. A variety of factors have been suggested to play a potential role in ED. Restless behavior upon emergence, of course, causes discomfort for the children, for the PACU nurses, and of course the parents, who usually are in there with the kids and they see them thrashing around and they don't like it either. Some suggested factors related to the transient emergence agitation are noted in the box below. A dose-dependent effect of SIVO, which increases EEG, has been proposed, and it's all nonsense. These children may require analgesics or sedatives, which can mean if you're sedating a kid in PACU, then they're not going home as fast, right? That's obvious. If you got to give them Versed or something to get rid of the agitation, then, get a chair, because they're going to be in there an extra hour or an extra hour and a half. These children, it also places patients at an increased risk for falls, disruption of surgical repair, the incision line, removal of tubes and lines. You know what combative patients are like and all the issues that nurses have to deal with. It kills kids and adults. Preventative measures include reducing pre-operating anxiety, post-op pain, providing a quiet, stress-free environment for post-anesthesia recovery. You ever been in a PACU in a modern hospital? Is that stress-free? Quiet? Oh my God, it's Grand Central Station. Treatment may include small doses of Versed, ketamine, fentanyl, clonidine, or Precedex, dexmedetomidine, dexamethasone, or an NSAID. Reuniting the child with their parents is also helpful. We tend to do that right away anyway. Right. So possible factors which would lead to this issue of emergence agitation from the kids I got them the little bullets on the bottom. It may be something to do with the DES or SIVO, the fact that they wear off so fast. The patient may be in post-op pain. It seems to be more common in airway surgery, ENT type procedures, but of course that's what kids go to surgery for, right? Myocardial tubes, tonsillectomies, so it may seem like it's more prominent in ENT, but that's because we do ENT surgery in kids all the time. So maybe we're just seeing it more often now. Age, of course, is a factor. Pre-op anxiety, if they were very nervous, maybe that previous hospital experience, the type of induction, if you get a mask versus propofol, the child's basic temperament or personality, some other medicines given, and behaviors including non-purposefulness, eyes averted, staring, closed, or unresponsive during early emergence. So the basic thing is, some kids, even up to teenage years, can wake up combative. It's transient, it only lasts 5 or 10 minutes. That does mean you have to stand there and watch them so they don't hurt themselves. And you got to get mom and dad involved and calm them down too, because they get all nervous that their kids are thrashing around and so on. So it requires your high level of critical care nursing skills to take care of the patient. All right, let's go to page 133. Page 133. These are little drawings I took out of this book. The references there on the bottom. I just kind of like the way they do this, so I put them in here. It's a nice review. It's a way to repeat it myself and just kind of say things over and over again. So let's take a look at this. These are the effect of volatile anesthetics in the body. I'll go clockwise around, starting with the head. They decrease CMRO2, well, we know that. Loss of consciousness, that's what anesthesia is. They can lead to post-op nausea and vomiting. All the gas anesthetics can, but especially nitrous oxide. They cause respiratory depression, analgesia, and immobility. That's what the MAC is. The patient doesn't move when the surgeon cuts. They cause myocardial depression. They can lead to arrhythmias. They cause anesthetic preconditioning. That's protecting the heart. Remember we talked about that? At least methoxyflurane or penthrane cause nephrotoxicity, but that's not on the market anymore, so nobody cares. They can depress cellular immunity. That's the nitrous oxide immune depression thing, is what they're talking about with the methionine synthetase and vitamin B12. Going up the other side, they can produce some skeletal muscle relaxation. They're lousy, but they do produce some. You still have to give IV muscle relaxants. They can be triggers, of course, for malignant hyperthermia. Hepatic toxicity was associated with halothane. That's not true of the modern anesthetics. They produce bronchodilation, vasodilation, supraspinal analgesia. That means analgesia at the level of the brain. Supraspinal is above the spinal cord. And they potentially produce developmental neurotoxicity in young children less than 3 years old. So those are the kind of things we kind of talked about, right? And the next page is nitrous, because that's a little different. They say nitrous oxide and xenon. Xenon is a noble gas off the periodic table that they've talked about for 20 years as being a substitute for nitrous. It never goes on the market. It's dumb because it's too expensive and nobody's ever going to do it. So you see it in the books, just don't pay any attention. So here's nitrous oxide. I'll start at the top. Decreased CMRO2, loss of consciousness, of course that's anesthesia. Spinal analgesia and immobility. It does not produce myocardial depression. Decreased respiratory rate and increased volume a little bit. No vasodilation. Produces analgesia and some developmental neurotoxicity. So there we go. To summarize on page 135, I took this out of, this is a British book, Aikenhead, very famous British textbook, and I kind of like this table, so I put it in here. They're comparing the three big gases, fluorine, DES, and SIVO, as far as their kinetics, which ones rise in the lungs the quickest. Fluorine, they call it moderately fast, and DES is fast, and SIVO is fast. Recovery with fluorine is moderate, with DES is very fast, and SIVO is fast. Hepatotoxicity, none of the current modern anesthetics do it. As far as metabolism, trace amounts for everything except for SIVO, 5 to 8%. Musculoskeletal relaxation, they're calling it moderate. It's kind of lousy, but you know, I'll go moderate. Respiratory system, respiratory irritation, both ISO and DES can do that. SIVO does not. That's why we use it for the mask inductions, because it's not bad to breathe. CNS activity, seizure activity doesn't mean anything. That's nothing. Renal toxic metabolites, no. Okay. On the next page, there's some advantages and disadvantages. Page 136. We're saying the same thing over and over again, so you're going to throw something in you. We're going to keep repeating. Let's start with nitrous oxide, some of the advantages. Analgesia, well, that's the biggest to me. That's the only reason we really use nitrous anymore, is it's a pretty decent analgesic. The other anesthetics don't have analgesic properties. Here's what they say. This is the coffee room thing, right? They say that if you give 50% nitrous, that's equivalent to about 15 milligrams of morphine IV, analgesia-wise. So 50% nitrous is, if you turn your dial, that's the same as about giving somebody about 15 milligrams of morphine IV. So it's pretty good. It's nothing to shake a stick at. It's decent analgesia. It's certainly not enough for us. We got to give lots more for surgery, but it's a nice start, right? Plus you can get in and out in 5 minutes, so why not? Rapid uptake and elimination, little cardiac and respiratory depression, non-pungent, in other words, it doesn't stink, you can't smell it at all, it doesn't have any smell. It reduces the MAC of the more potent agents. So the more nitrous you give, the less you got to give of the real gas, SIVO, DES, or fluorine. But again, the back of the hand calculation is for every 10% more nitrous you turn on, you can give 10% less gas, DES, SIVO, or ISO. So if I'm giving 50% nitrous, I can give 50% less SIVO along with it than I normally would if I wasn't using nitrous. You see what I'm saying? And it's not exact and it's not scientific, but it's kind of a general rule. And it undergoes, finally, minimum biotransformation. It's only metabolized to trace amounts, so it's not enough to worry about. Some of the disadvantages of nitrous, on page 136. Expands, of course, closed spaces, we know about that. Requires high concentrations, which limits the amount of oxygen you can give. Causes diffusion hypoxia. It has teratogenic effects in animals. Makes POMV. It supports combustion. If you had an OR fire, you got to turn off the nitrous because it's got oxygen molecules in there. It can help support the fire. And it causes immune suppression. So those are the downsides for nitrous. Okay, fluorine. Again, moderate muscle relaxation advantages. Decreased CMRO2, trace amounts of biotransformation, no significant toxicity in any organs, and it's cheap. Possible neuro and cardiac protective. Isoflurane been around since the 70s, so it's generic and it's probably the least expensive anesthetic gas. The downsides, the disadvantages, pungent odor, it's kind of stinky, you can't breathe it too well. Airway irritant, it's a trigger for malignant hyperthermia. It's the slowest of all three, DES, SIVO, and ISO. ISO is the slowest. And again, trigger for, I repeated myself, trigger for malignant hyperthermia. DES, advantages, rapid uptake and elimination. It's the fastest anesthetic we have. It's minimal transformation, biotransformation, very stable molecule, no significant toxicity, and possible organ protection. On the downside, it's an airway irritant, the most irritating of all the gases. It's expensive compared to the other agents. Needs a specially electrically heated vaporizer. Requires increases in inspired concentration. Can lead to death-threatening tachycardia. And it's a trigger for malignant hyperthermia. Finally, on the next page, 137, SIVO. And the nice thing was, the advantages of SIVO, it doesn't smell, non-pungent, so patients will readily breathe it without irritation. Rapid uptake and elimination, it's excellent for mask induction. Cardiac effects broadly comparable to Forane. Possible organ protection. The downsides, it does react with soda lime. I'll talk a little about that tomorrow when we come back. It's a trigger for malignant hyperthermia, and there is some biotransformation, 5 to 8%. It doesn't seem to be an issue, but we never like to see biotransformation. We'd rather see the drug come back out the way it went in, without being metabolized. So that's SIVO. Okay, any questions? See you tomorrow.